Hello, everyone, and welcome to the Physio Pulse podcast. I'm your host, Jeff.
And I'm James.
And today I've upped my game. If anyone's watching this on YouTube, I thought that I best dress for the occasion, unlike James, who's wearing a Great Swim t-shirt. Not making the effort at all, don't know why.
We definitely didn't agree on this beforehand. But for those on YouTube, Jeff, can you just have a little stand up maybe?
Oh, yeah. My lovely trousers.
For those who can't see, Jeff is business on the top half, and I don't know what to say for the bottom half, Jeff. How do you describe?
Yeah, I actually dressed like this for my interviews a few years back. Thank God they didn't ask me to do anything stuff.
Just a suit on the top half, and was it sweat shorts in the bottom?
Starkers, nothing.
Starkers. And you can find us on OnlyFans, the Physio Pulse.
How have you been, mate?
Yeah, good, mate. Yeah, I've just come back from 10 days off, so feeling refreshed and raring to go.
Beautiful. Was the inbox as big a bomb site as you thought it was going to be?
Oh yeah. Use System 1, which is like our program that we use for all our patients, and it lets you tasks like instant message people. And I came back and I had like nearly 100 of these instant messages on my profile. So yeah, it was a lot to come back to. And then my emails as well. So we had another
the joys.
Yeah, the joys of coming back. What about yourself, mate? How are you getting on?
Yeah, good. I went up Snowdon for the first time at the weekend.
Nice.
And could see about 2 meters in front of me the whole way up.
Typical British mountaineering.
Yeah. We went up on Friday. Started off at 8:20 in the morning, so it was nice and clear.
Oh, nice.
People-wise.
I was going to say I was up Slieve Donard in Northern Ireland, but that was on Saturday. I was going to say we'd be on two of the highest peaks in the UK at the same time, but a day apart, unfortunately.
Tallest man in Northern Ireland, tallest man in Wales. I also had a interesting experience in work this week.
Oh.
Something that's taught me the importance of the Kieran O'Sullivan test. You say to your patient, so what are you going to tell your family we discussed today when you get back to clarify understanding? I'd recommend it to everyone so that you don't get into a situation where things come back to bite you.
What happened to you?
I cannot divulge exactly what happened to me, but I would encourage everyone to do the Kieran O'Sullivan test.
Okay, you left us in suspense. Great story for the listeners there, Jeff. Great story that happened to me, but I can't tell you. That's really good for podcast.
It was meant to be my segue into our paper today, actually.
Oh, okay.
You've completely ruined it, as you ruin everything. Because today we're discussing everything cognitive functional therapy.
We are.
What are your thoughts on cognitive functional therapy, James, and what is it?
That's a great question. And to be honest, I wouldn't have been able to tell you that a week ago. So it's been interesting reading a bit more into it. But yeah, cognitive functional therapy, essentially it's a framework to help patients with chronic pain. And it was developed by Peter O'Sullivan, who's obviously a big dog in the physio world. I'm sure most people are aware of him. It's essentially using a lot of the biopsychosocial framework to help guide a treatment. So essentially you're trying to provide the patient with an explanation as to why they're in pain and make sense of this chronic pain. So obviously it's often very confusing for patients because often a lot of scans have come back showing nothing, or the pain is very variable and they're struggling to make sense of it. Often they've been told a lot of different things as well. So it's unpacking that and explaining it to them. And then it's trying to build their confidence in movement. And it's often exposing them to things they thought they're unable to do and showing methods of getting around that and slowly allow them to do things they weren't able to do previously. And finally is lifestyle change. So trying to implement this long term and allow them to do more on a day-to-day basis. I think the good thing with this is a lot of this is what we'd consider very good care, isn't it? There's definitely principles in it that we'd hope that a lot of our colleagues are doing with patients.
Absolutely. I think that, one of the comments I made about cognitive functional therapy is, at the very least, it's not noceboing anyone.
Yeah.
You're not going to give someone an unhelpful narrative. And at the end of the day, if that's all we do and support someone through it, then you're probably going to be better than half the bullshit that's currently being preached and practiced.
Completely. Yeah, completely agree. I'd go a step further than that, though, as well. I think one of the biggest powerful things we can do as therapists is to actually listen to a patient. And it really stresses the importance of validating that patient and spending that time to listen to their story. I think Peter O'Sullivan often recommends you start your assessment with, tell me your story. And it's such an open-ended question, and it lets the patient start at wherever they want to start, which often isn't where we want to start. And I think that in itself, along with without the bullshit as well, is, I think, really powerful.
I absolutely love that. And it's the whole validation and tell me your story, because that actually reminded me of a paper by Gilletta Belton, who's like an expert patient who, I don't know if you've read any of her stuff, but she's quite active on Twitter, and she's a person who's got persistent hip pain, and she's written a paper, which I'll link to our Dropbox, the link on Instagram. It's called Patient-Centered Communication. And a part of that is all about telling your own story. And it's a bit cheesy, but the line that she puts in that really resonates with me is, we are the stories that we tell ourselves. And she gets that from an author who's saying that who we are is being formed in what is told, what we tell ourselves. And so the kind of psychological bit of this and the cognitive side of the cognitive functional therapy is maybe trying to evaluate your story and making sense yourself of where you've come from, and actually, am I as broken as I thought? And are they reinventing themselves a little bit through this telling of the story and breaking it down? I think I love that side of it.
Wow, that's really powerful, isn't it? And I completely agree. I think that's a huge part of why it's effective.
Yeah. So today, the paper that we're discussing, because there are quite a few papers on CFT, and we can't do them all justice, but we've gone for the biggest randomized control trial that they've done, which was released just last year in the Lancet, like the highest impact journal you can have. We won't mention the whole vaccine thing, but we'll skim over that. But yeah, highest impact journal, and it was actually featured as well. It was like on the front page, so it was a massive trial. Got everyone talking, everyone who loves back pain and everything pain science. And we both missed it, apparently, at the time. So we're just going to quickly whiz through the methodology so then we can kind of get into the nuts and bolts of it. And I feel we're a little bit nitpicky today, aren't we, James? We're in a nitpicking mood.
Definitely, yeah. Considering we both like CFT, I think we've both been quite harsh, but yeah, we'll see where we go.
Yeah. So this is the 2023 paper. Lead author is Peter Kent. We've also got loads of other big names, including Peter O'Sullivan and Kieran O'Sullivan, JP Canero. Loads of big names on this. And it's the Restore trial. So the full title is Cognitive Functional Therapy with or without movement sensor biofeedback versus usual care for chronic, disabling, low back pain. A randomized, controlled, 3-arm, parallel group, phase 3 clinical trial. Yeah.
And breathe.
So this was a 3-arm randomized controlled trial. It was completed between 2018 and 2020. It was pre-registered, as we mentioned last time. We're going to talk about that a lot. It was class. They kept to everything, and it was prospectively registered. So I'm not going to go into that. It was held across 20 primary care physiotherapy clinics in Australia, and the 3 arms were usual care, which they didn't have any control over, cognitive functional therapy, or cognitive functional therapy with biofeedback, so wearing sensors and getting feedback from that with regards to movement patterns. Their primary outcome was to look at disability using the Roland Morris Disability Questionnaire at 13 weeks, but they also followed them through to a year as well. They collected a whole host of secondary outcome measures. The average years that people were in pain was about 4.6 out of 10. The average pain was 6.2. and the disability was 13.6 out of 24, with 24 being the worst on the disability questionnaire. So quite high levels of pain and disability compared to previous trials.
I think it's worth mentioning that with the Roland Morris disability questionnaire, most back pain trials are below 10. So this is quite significant, more disability than most other back pain trials show.
Oh, wow, I didn't know that. I knew it was high, but I didn't know it was like significantly high, because about 4 or 5 is the minimal clinically important difference, isn't it?
Yeah.
So, wow. Yeah, and so essentially people either went for usual care where they didn't have any input from the authors. They just filled out the questionnaires at 13 weeks and a year. And then the other two groups, the CFT, had 7 treatment sessions over 12 weeks, and they also had a booster at 6 months. They were allowed 60 minutes for the initial and then 30 to 40 for the follow-ups. Essentially what they found is that cognitive functional therapy with or without biofeedback was better than usual care at 13 weeks and sustained effects at 52 weeks for disability. Pain was not as severely impacted for the better, and there wasn't huge differences really between groups. So we'll get into the nitpicking. What are your thoughts on it, James? Did you like it?
Yeah, it was a really interesting study to read, I'll say, to start off with. So I did like the study.
But there's always a but.
No, I was going to stick on the nice stuff first. I mean, it's great to see such a large study, and I thought it was really interesting what they were trying to do. They were obviously aiming for this more pragmatic approach. And I was listening to an interview from Stephen Sullivan fairly recently on another podcast. Can I tell them what podcast it was, or is that sort of fraternizing with the enemy?
It's fraternizing a little bit, but go on. We can't make enemies at this stage.
It was the E3 Rehab podcast, and it was great. It was really interesting, and he was sort of saying, look, the criticisms of CFT previously have been that it's not been very pragmatic. So the exact point of this study was to say, look, let's just see what it's like versus usual care, and let's see that if we gave them this intervention, what would happen, basically. So I really like that. I think also just the concept of CFT really fits with my bias. I don't know about you, but especially with these chronic pain patients. So I really like this sort of idea that you're listening to the patient, you're really validating them, you really listen to their story. Most patients just value that. There's so many times in clinic where actually you just listen to the patient for 30 minutes, and actually at the end of them they say thank you, and you haven't got to the objective because you've run out of time. So I think that's so important. Yeah, and then mixing it with the lifestyle factors, and then obviously promoting more movement, I think is a really good thing. So I really like that. I really also loved the idea in this study of investing more in clinicians. Like, so often the expensive intervention is something like surgery, and actually this is a study saying, well, actually, let's just give loads of input to clinicians.
So what training did the clinicians get then?
So for the CFT group, this was done by 18 different physios over 2 main sites. So it was done in Sydney and Perth, and the clinicians were trained over 6 months and had 80 hours of training on average between them. Not between them, each as an individual. Individuals had that. So they were doing clinical workshops. They were doing a lot of pain science initially. And then not only that, they were having sessions with patients with actual chronic pain patients recorded, and then watching them back with mentoring to discuss what they could have done better. And they even did group sessions where they treated somebody with Peter O'Sullivan and Peter Kent in the room to demonstrate and to sort of guide them through the assessment as they would. So it's a huge amount of input. There's mentoring, clinical workshops, video, all these things over 6 months and 80 hours. So it's a huge investment in staff. But I actually really like that. We're sort of saying, look, can we actually, even with all that investment, does it give better outcomes? So I did like that concept.
I love that, because we've both worked in places that, funding for any kind of education is limited, and it can be quite demoralizing. So you go to work and you don't have any fresh perspectives, and you've got a full list, and actually your motivation and probably rapport with the patient takes a bit of a dive from it. You can get a bit burnt out. So actually having this training, will actually give people some enthusiasm, I think, and that
Yeah.
counts for so much, especially with people who everything's doom and gloom with the back pain. It's limiting them with doing everything. Come in and see someone who's nice and bubbly and can talk you through this stuff versus someone who's a bit, oh God, 10th patient today, it's going to have a big effect.
Massive. And this patient group is a very challenging patient group. They're going through a lot. They're having a really hard time with this, and they require a lot of input. And unfortunately, it is seen often as, I'm sure we both heard it, and I'm sure everyone listening has heard it from colleagues saying, actually, oh God, I've got this person coming in who's had chronic back pain, and I really don't want to see them. They've got all this going on, and that's just the unfortunate reality of what some people think of it. I think it's changing. It's definitely changed since I've qualified, but slowly.
Yeah, no, it is really hard, isn't it? It's hard when you're emotionally invested, I think,
Yeah,
and so the quick learn thing is to become less emotionally invested, and it can be easier, but that results ultimately in not the best care you can offer someone.
definitely. And also, I think sometimes people go for the simplest answer, and often it can be, especially I've seen it when I first qualified, is people would say, "Oh God, this person's exaggerating," or they're moaning about something that isn't a big deal, or they're exaggerating the pain. Or they've said it's 10 out of 10 on the scale. That must mean that shows what sort of person they are. So it's almost like blaming the patient, and it's an easy way out rather than thinking, actually, this person's in 10 out of 10 pain. That just shows how much they're struggling. I'm trying to get a way out of having to deal with this more complex person.
That's definitely our rational brains talking. I know we've both been in that position as well. I wouldn't want to give anyone the impression that I'm above that, because it does get to you, the situations that you're working in. I suppose it's just trying to strive to be better, isn't it?
Definitely. And be aware of that. Like you say, we've both been there. We work in the NHS, both of us. We see these patients as a massive part of our patient cohort. But being aware of that bias and trying to check yourself and realizing this individual in front of you is really struggling.
Yeah. One of the points that I've kind of thought about with this trial is the primary outcome measure is disability.
Yeah.
What's your thoughts on that? Because I know it's a bit mixed, isn't it? Like I've seen some people say that actually that's a really good thing to look at. What would patients say, do you reckon?
Yeah, that's a really good question. Because I noticed this as well. I actually quite liked it. So because I tend to, from my experience, when I'm seeing these more chronic patients, when you ask them what do you want out of this, often the main answer you get is, I want to be able to do this. That's what I would generally think. Normally is, I want to pick my child up, or I want to be able to walk to the shop. I want to be able to work. I think often it's more what's stopping them from doing. So I actually quite like the disability was focused on.
Yeah, I'm really conflicted with it because I like it, because I have got to the stage in my career where I've accepted that the role that I can have on someone's pain is unpredictable. And it's so multifactorial, but patients definitely aren't at that point. And so I have the same thing. People come in and say, "Oh, I need to work," or "I need to get some quality of life back because I've got nothing at the moment." But the way that they see they're going to get that back is through pain reduction. And I don't know how many people are readily accepting of the fact that pain might continue. And so I do try to have those conversations with people saying, if we can't change your pain, is working at just trying to live better with pain something that you're interested in or not? And it's probably an important question for us to kind of ask clinically, because the people who are engaged in this trial obviously were open to that.
Yeah, that's interesting. Yeah, that is interesting. I think the only thing I'd say is, I would say people expect the average time was 4 years, wasn't it, to have back pain in this study? Is that right? So they had back pain for 4 years, and these are also people that have had quite significantly disabling back pain as well. I don't know. In that cohort, I tend to have found that a lot of people in that cohort have come to that conclusion themselves. They don't think the pain is going to change. By that time they come to you, like sort of 4 years in, they usually have tried a lot of things and have and I've sort of realized actually this hasn't changed. So yeah, I don't know. I tend to find that disability is more of a thing for them, but that's interesting to hear your side of that.
Yeah, it's definitely mixed, isn't it? I think people are reluctantly accepting, but if there was a chance there was anything that could lower the pain, obviously you'd take it
Sure.
because
Yeah.
who
Yeah.
wants to be in pain?
No, definitely. Definitely.
What about the time frame, mate? Because collecting it at 13 weeks, was there any justification for that? Or
Oh, that's interesting. No, I didn't see that. Yeah. What was your take on that?
well, the cynic in me is thinking that they will have just finished CFT, so everything will be fresh in the mind. But then they've kind of, that's not really a valid point because they've also collected outcomes at a year. So, but yeah, the
Yeah.
cynic in me was thinking, I wonder why they've chosen 13 weeks. Is it to try and maximize their scores at that point?
Yeah. I suppose, or maybe was it? I think I'd agree with you. They probably did it when CFT finished, but is it also to compare how much it dropped off after the 12 weeks? Just wanted an accurate measure of what they were like directly after treatment, and then so they could see the natural drop off or maintenance.
Yeah, yeah, you're probably right. Immediate treatment effects.
Yeah, which is probably an
Yeah,
important thing to know, isn't it? So we'll let them off the hook with that one.
yeah. Okay, fine. I'll concede.
Yeah.
I'm trying to be too nitpicky. One thought that did cross my mind was where were the usual care group at this point?
Yeah.
I feel like the usual care group should be renamed to the crack on and I'm sorry you're not in the CFT group.
Yeah. So this, I think there's some important distinctions here. So in the three groups, obviously there was usual care, CFT only, and CFT plus biofeedback. So the CFT, both the CFT groups could access usual care. So they were getting that plus CFT. And you're right, the usual care group wasn't blinded. So they were basically told, you go into the study and you could get this like new treatment. And then they go randomised, they get a phone call saying, sorry, crack on, we'll catch up with you in 12 weeks' time. Just do what you normally do and see how you get on. So they know for definite they weren't allocated to the to this magic group. And that's a massive nocebo.
Yeah, definitely for some people. And we're both from UK, so we don't really clearly understand what usual care looks like in Australia. But reaching out to a few people, I'm aware that there is kind of a subsidy for physiotherapy appointments, about $50 a session for like 6 sessions. But if you want to make a living, you need to charge more than $50 a session. So people would have to pay out of pocket for that. They can also, obviously get imaging, get told nocebo, like degenerative discs, arthritis, incurable arthritis, even be referred through for medial branch blocks and facet joint injections. And so one of the thoughts that I'd had was this isn't an efficacy study for CFT. So an efficacy study is to look at in controlled conditions compared to a sham. What is the difference? So we can say that in controlled conditions, CFT is better than doing nothing. But part of me wonders we know that nocebo is such a huge thing, especially with back pain. There's so much dogma out there, and so few accurate kind of hypotheses and theories that people transmit. I wonder if actually that might have contributed to worse outcomes, coupled with knowing that they're just in the usual care.
Definitely.
And is there any chance that could have inflated the effect sizes between the groups? What do you
Definitely.
think?
I completely agree. I think it's probably worth us noting as well what nocebo means. I think a lot of
Yeah.
people have heard placebo. And essentially, nocebo is the opposite. So you get effects from someone putting fear into you, basically. So in healthcare, the common one is your back's falling apart, your discs are crumbling. And we all know from clinical practice what that does to patients. You see them coming into our clinics and they're frightened to move. They think that they've got all this fear of what they're meant to be doing, and that creates poor outcomes. A nocebo could also be something like, for instance, in this circumstance, is that you think that you've got there's this fancy treatment being withdrawn from you, and the nocebo would be like someone saying, "Oh, you're not in that group; you're in the usual care group." So even the fact like calling it usual care or crack on group would be a nocebo.
Yeah. And the poor guys at CFT can't win, can they? They've been nitpicked for not being pragmatic enough. And as soon as they are, like, well, we don't even know what usual care was.
I know, I do feel sorry for them, definitely.
I found it interesting as well that the usual care group were the only group compensated financially to fill in the questionnaire. Again, just if I was in that group, I'd be thinking, oh, like I'm the only person getting paid because I haven't had what's actually valuable.
I see. Yeah. So why are they paying me and not the other people?
Yeah.
That's a really good point.
Yeah.
So yeah, I think you're right. I think that's a massive concern I have with this is the usual care group, and the fact they weren't blinded is a massive thing for me.
You kind of can't be though, can you?
Yeah, true. That's a good point. It's a difficult. It's difficult to blind usual care. Definitely.
Yeah.
The other thing might be worth making clear is both the CFT groups, even the one that didn't use the biofeedback, still had the sensors on. So they both did the CFT with the sensors on, and so essentially these people are getting this fancy treatment, or they've told you've been selected for this treatment in the study, and you're going to put these fancy bits of kit on you, and you're going to have, I think they had 7 sessions in the first 16 weeks. So you've got like quite an intensive period of one-to-one therapy with a lot of time input as well. And I just wonder how much of a placebo that has on them as well. Would it be worth us mentioning what the biofeedback was for as well?
Absolutely. Please go ahead.
So the biofeedback was sensors, I think, at the top and the bottom of the lumbar spine, and essentially allow people to know what position their back was in. And it gave real-time data to them. So they had like a little iPad, and it had a mannequin on the iPad, and that would basically demonstrate what position they were in, how much they were bending. So when they were teaching them as part of this cognitive functional therapy, this CFT approach, we mentioned the second stage was this exposure to movement. So once you explained about the pain, you try and expose them. And a lot of that is saying things like, have you tried, rather than bracing, have you tried allowing your spine to bend a bit more and naturally and relaxing it? And they could then visualize that on this biofeedback. And then they actually took these sensors home with them with the iPad. And it meant that for the next day, they could actually have prompts on it. So it might remind them, for instance, you've been sat down for 20 minutes, actually relax your back. And that could be a little prompt that comes up, your back's too stiff, so let's relax it or move. And actually got the prompts for another day. So it's a lot of input with it. But interestingly, obviously, it didn't show any difference when they actually had that compared to not having that feedback.
That's really cool. And it's really surprising that it didn't have an impact. I for sure would have thought, yeah, I definitely would.
Yeah,
maybe it just gets annoying.
Yeah, because you'd think like, God, you've got this thing that goes back with the patient and literally reminds them to do what you've been telling them in session and almost makes them do it there and then. You would have thought that'd be a winner, but it didn't, which I found really surprising.
Yeah, I mean, I'd definitely get pissed off with it.
It's
like, for fuck's sake, I'll move then. Jesus Christ.
Can't tell me to sit straight, stupid machine.
Yeah. I was quite interested in this idea of what was the active ingredient, because for CFT, I think it helps for it to be branded and to act as a framework for people who haven't maybe arrived at these conclusions themselves through practice anyway. And in order for them to kind of teach it, it needs to have a brand. But at the same time, like, a lot of this is just good practice. Like, you should be listening to patients. You should be validating their concerns, and you should be gradually getting them back to what they want to do with safe messages. That's just good care.
Yeah.
And so I'm interested in what is it about it then? Because is it degraded exposure? Is it just listening to someone? How much of each of these variables count towards the end result? Do you have any kind of thoughts on that?
Yeah, no answers, I'm afraid, but a few thoughts. I think I would say a big part of, I've got no proof for this, but I would imagine a big part of the effects they saw was the fact that ultimately you've given clinicians 80 hours of training with, Peter O'Sullivan, Peter Kent, these are big names in the physio world, very good communicators. one-to-one mentoring, real-life practical clinical work with their mentoring, and you give them that for a solid block over 6 months, and then you put them in with this patient group, I would imagine a large bit of that is just you're communicating a hell of a lot better when you've had that much input. Like, I know it'd do wonders for my care. If I had that input, I'm sure it'd be fabulous. I'm sure I'd be treating people way better than I am now. But yeah, I'd imagine that's a big part of why it did well.
Yeah, there was actually, because I was interested in it, I looked a little bit further, and there's actually a mediation analysis done in 2020 for a different study regarding cognitive functional therapy. The lead author on that was O'Neill. And so essentially they were looking at, from the patient-reported outcomes that they collected, what explained the change in presentation. They looked at different things like stress, coping, sleep, fear, self-efficacy, and they found that actually stress, coping, sleep, and fear weren't mediators of change.
Oh,
And
wow.
fear was a big one for me, because I would have for sure said fear of movement and reducing that will help pain, but that they didn't find that in this study.
Wow. Okay.
What they did find, though, was actually self-efficacy did come out as a mediator. So essentially, having confidence to perform activities in the presence of pain, kind of knowing that I can do this despite the pain that I've got. And that's quite interesting.
That's fascinating. Yeah.
Is that something that is talked and actually it's cognitive? Is it something that's experienced with the graded exposure? It'd be great to kind of delve into that a little bit more. And they have said from that, that's just exploratory research. You can't confirm a hypothesis with that. It just leads on to more targeted studies in the future.
No, but I love those types of research where it just makes you go, oh, that's interesting. And it just makes you want to ask the next question. I think that even though, like I say, it doesn't prove anything, I think that type of research is important. Just make you question things. And I'd be interested to see what they come up with. I think also there's meant to be a 3-year follow-up for Restore coming out this year as well, which will also be interesting for us to look at when it comes.
Oh, decent. Maybe we'll just be fully converted by then and just nitpick.
Yeah, the CFT podcast with James and Jeff.
Completely selling it wrong.
Yeah. I would like to take, just before we become full converts, I would like to dunk on it a little bit more, if that's okay in this podcast.
Oh, yeah, go on.
Yeah. I think you mentioned it a little bit before, that these authors obviously teach this framework, the CFT. So I don't think this is highlighted enough in the paper. When you look at the limitation section, it's very short. And considering we've got like a page of notes we've written on potential limitations of this, I was surprised they wrote so little in the limitations and they weren't more self-critical. And for me, that's a bit of a red flag. Both of them, so Peter Kent and Peter Sullivan, both sell CFT courses. And to not sort of highlight that more and to not highlight some of these other issues we found, to me, is a little bit concerning. And it sort of smells there might be a little bit more bias in this paper.
Would you say that's a limitation of the methodology, or is that just a conflict of interest?
Conflict of interest, I'd say. Because you're right. I think the methodology was good for what they were trying to do. I think, but even in terms of things like how it was delivered, maybe to patients, they've got a lot of skin in the game, haven't they? I'm just concerned that carried over into the study.
Yeah, I agree completely, because we're reading the end product, and even though everyone involved with CFT seems like really intellectually honest and very open to change and criticisms, it is still their baby, isn't it? And so the big thing that needs to happen now is replication, and that's a pipe dream because they never get fucking replicated ever.
Yeah.
But that's really what we need, because these effect sizes are large. An effect size, to explain it briefly, is the magnitude of effect, the magnitude of difference between two groups. So that's exactly what an RCT is there to look at. It's not there to look at the change from baseline to 13 weeks. It's there to look at what's the difference between the groups at 13 weeks and 52 weeks. And the CFT groups and the usual care group were massive for physiotherapy trials. They were moderate and large. I think it was between 0.6 and 1. I can't remember off the top of my head. But they were really large effect sizes.
Right.
And what we usually see is like 0.2, 0.3, 0.4. So what I'd really love to see is a different author group produce this and have similar outcomes. Then I'll be a bit more sold.
Definitely. I completely agree. Some of these other points I had down here, we've sort of mentioned a little bit already. Obviously, the control group, the usual care group, they were just going through the medical system. So they had no help with that. They just were able to do what they'd normally do. So when you look, I think it was 60% of people didn't even look for care. They weren't trying to access care for the pain, which obviously makes a massive difference in not having any care. And on average, the usual care group only had just 3 points of contact with a medical practitioner in a 16-week period, which is when the first measurement took place. But the CFT group obviously went through that course. So they had 7 contacts, and those contacts were an hour for the initial and 30 minutes for the follow-ups, etc. So you're getting a lot more input there. So actually, again, is a lot of this just that you had this very intensive period of someone listening to you, long, large periods of time with a healthcare professional. I wonder how much that explains the effect as well, rather than necessarily being the specific approach that helped.
Yeah, that's bang on. I think hopefully that can be demonstrated in future trials where it's a bit more controlled for different groups. I think it has. CFT has been compared to manual therapy and exercise previously, and I think Match for Time and came out on top in that study. I think it's one of the limitations of the design, isn't it? You can't control for that.
Definitely. But then again, like you say, they can't win because it's a pragmatic study. So they would just say, well, look, we were trying to make this a real world scenario. And also, in their defense, they could argue, well, actually, we're showing that if you gave people an intense period of 7 sessions and invested in that heavily, then you could get good outcomes. So in their defense, it is good from that point of view. They're saying that the current care isn't working. One of the things I really liked about it, I was listening to Peter Sullivan speak, and he was saying that hopefully this highlights the importance for longer sessions with physio. We've been doing this thing over many years, is that it's getting smaller and smaller. Your new patient slots shorter, your follow-ups are getting shorter and shorter. And we're trying to narrow down these margins, thinking we're getting better value care, but actually we're probably not. And actually we're missing the mark with these patients. And he had this great quote where he said, you wouldn't expect to see a psychologist in 20 minutes, 30 minutes. So why are you expecting us to see these complex multifactorial pain patients in 30, 20 minutes and expect to have a good outcome? You're just not going to get it. So hopefully this might just demonstrate that actually you can get good value for money and good outcomes if you invest a little more time in these patients.
That's such a good point. And especially for public healthcare systems like the NHS, they did do a cost effectiveness analysis in this as well, which I'm not even going to attempt to go into because it's a bit more complicated and statistically than I'm used to. But they have shown that can be cost effective. And especially in the NHS, we get 30-minute time slots on average. Some places get 20. And that's very much a product of times gone by where it was get people in, move what's stiff, give them a few exercises to strengthen what's weak. That's all people need because it's all biomechanical, and send them off. And then as our understanding of the evidence has evolved, we just haven't kept up with that, with our infrastructure of how we deliver care. And so that's a really big thing for me. I actually have 45-minute slots available specifically for this reason. I'm in a luxury where I can kind of dictate what I have for certain patients. So, but that's not the same because productivity would dip if everyone had that. So it's a complex area, but for sure we can definitely get benefits from investing more time.
Definitely. I think the final point that I wanted to make that I thought again was just interesting was that I think this presents itself as a paper where it's treating people who other clinicians struggle with. So this is like the group of patients that are more challenging to treat. But then actually when you look at their inclusion, it was they initially screened 1,000 patients, is it 1,100 patients for this,
Yeah.
and then they took out 51% of them, so more than half were taken out. And it appears to be that's because they chose people who they thought would do better with cognitive functional therapy. So again, massive bias. And actually, if you're excluding 50% of the patients, does that mean actually this is that? What happens if you didn't do that and actually just randomized it? Would it help those patients more?
Yeah, it was a huge call. And actually, the inclusion criteria wasn't that rigid, and neither was the exclusion criteria, which is why so many people were eligible to be considered. And actually, yeah, cutting out 50% is mad.
Yeah, I was really surprised they did that. And again, just talking about this bias, talking about like, maybe a bit of skin in the game. I just wonder why it was such a big call.
The other nitpicky bits that I had was if you look at the table that had the patient demographics in, they've collected so much data, which is great. One of the bits that they collected was the confidence that people have had in the treatment that they were assigned to. So the responses were very unconfident, uncertain, and then somewhat confident, confident, very confident. So I've kind of split that into like the first three is going to be negative expectations, and then the last three are going to be positive expectations. So in the CFT and the CFT with feedback, 73% and 67% had positive expectations that they were going to improve with CFT, compared to 25% of usual care.
Wow. Okay, what a difference. Okay.
Massive difference. And, the literature around patient expectations is quite clear. I think I remember Chester et al. 2016, prognostic indicators of success with physio for shoulder pain. And actually, what came out on top was people got better if they expected to get better.
Wow. Wow.
And that probably drives home what we were saying before is people don't have faith in usual care. And it's going to have a negative impact.
Yeah. Yeah. That's such a good point. That was really interesting. And what a difference between the groups. So there's obviously a big initial bias or expectation from the patients that they thought that cognitive functional therapy was going to help them. And maybe they just fulfilled what their bias thought. And maybe if you factor that in with the fact that this was sold as like in the treatment group and the other ones in the usual care group, they had these special biofeedback on. There's a lot of placebo maybe involved in that, a lot of bias, a lot of expectation. And I wonder again how much that had an impact.
Yeah. I suppose the question is then, James, so with this trial in mind, comparing 7 sessions plus a booster at 6 months in a heavily selected and culled sample compared to people who get pretty much no care at all and might be pissed off in the CFT group.
Yeah.
And didn't expect to get better. Would you pay for a CFT course?
Oh, that's good. That's a good question. You've definitely loaded that question as well.
That was neutral.
Do you know what? All jokes aside, I probably would. And I think, because ultimately, I think there's a lot of good things within CFT that all clinicians should have.
Yeah, I'm right there with you. I 100% am planning on doing a CFT course in the
future. Because you're right. I read this and I was really interested. It definitely fits my bias.
Yeah. And you know what? I don't need this study to tell me that validating patients, listening to them and gradually exposing them to the movements that they're painful with is a good idea. And actually, so we've both nitpicked it quite a bit, but at the end of the day, it doesn't really matter to me because I'm never going to just opt for usual care. Like I think that I need to get better continuously at communication and gauge exposure. And the authors, Peter O'Sullivan, Kieran O'Sullivan, Peter Kent, they're masters of that. They've been studying it and doing it for years. So I need to go and learn it from them really to try and be better.
Definitely. I'm a bit jealous of the clinicians that got 80 hours worth of their time in the study, to be honest.
I know, yeah. I wouldn't make the cut, I don't think. I'm not looking for physios to be like, oh, Jeff, just have a stand up for us, show us your trousers.
You'll be in the usual care group.
Yeah, I'll be the one receiving them all. Like, oh, fucking hell, there we go again.
By the way, you've set a real precedent now for these podcasts. I feel like I need to come in a suit next time.
I just wanted to make you look bad today.
Do you know what's terrible as well? Again, for those on YouTube, you're able to see, but do you see those splotches of colour just on the wall here? I'm in the middle of painting this room as well. So that's the 2 colour choices. Vote below on which one you think would be best for this room.
James, how long have they been on your wall? You're not in the middle of anything. You're taking about a year hiatus.
Do you know what? I think they have been at least 3 months on that wall.
Way more than 3 months, mate.
Oh, bro.
So, is there anything else that you want to mention about this?
Yeah, I think just overall, I want to say that we've given it a lot of shit, this study, but take it for what it is. It's a pragmatic study. I think the criticisms come if you try to take it as an efficacy study, which is not. So if you try and make it an efficacy study, there's a lot of criticisms. So you can't say that CFT works for these reasons. But I think we can say it's interesting. It's an interesting approach. It's a large study. It's something a bit different. I love some of the messages. I love the concept of CFT. I love the idea of investing more into physiotherapy, extending patient time. I think it gives us some really interesting avenues from there for further research.
Agreed. And I'd also like to stick up for the conflict of interest as well. I do think that it needs to be acknowledged, seriously acknowledged for the outcomes of the studies. But at the same time, like the skills that Peter O'Sullivan, Kieran O'Sullivan teach are really valuable. And you can't expect to get them for free if someone's teaching it. They need to be compensated for their time to do that. So I'm kind of okay with it, as long as it gets replicated by someone else.
To see them replicate it. And do you know what? We should definitely do an episode when the 3-year study comes out as well, just like a little update as to what they found.
Yeah, we'll just fanboy it. Yeah. No, mate, that was good. I've enjoyed it. I'd really encourage people to give it a read. There's plenty of information in there that we haven't even got to. And just a shout out for that paper that I mentioned at the start as well, the patient-centered communication. I'll link that to our Dropbox folder. So for anyone who doesn't know, we've got the links in our bio on Instagram. We've also got a link to our Dropbox where we're going to put all the papers that we discuss and any key resources as well in that folder. So head there to get this paper and any others that we've mentioned.
Brilliant. And also, I'm glad I managed to slowly move you up the body. I might even get you to a shoulder next week. We'll see.
You've got me like one bone above.
Slow and steady.
Great, mate. Well, till next time.
Nice one. Good seeing you, mate.
You too.